Thank you, Jean-Marie. Thank you for inviting me in this amazing meeting. It's a pleasure and an honor for me to be here in the home of School of Lyon. The number of pediatric ACL has increased a lot in the last year, with a 5.7-fold increase in pediatric ACL in US in the last decade. This is mainly due to early initiation of sports activity of the kids, hyper-specialization of youth sports, strict training regimens, the increase of year-round training, and also improved injury detection and early diagnosis for this kind of injury. Usually the main concern with the operative treatment for ACL in a pediatric patient is the risk of growth disturbances. But in my opinion, the major complication is the failure rate in this subgroup of very high-risk patients. Failure rate is up to 32% for pediatric ACL reconstruction. 50% of the failures are due to graft re-rupture. There is persistent pivot shift in many patients even after ACL reconstruction. And kids have 2 to 5 times greater risk of either graft rupture or contralateral ACL injury. So they should be considered a very, very high-risk population. Many papers in the recent literature show the effective role of exarticular reconstruction in the reduction of failure rate in risk population in adults. And same technique can be used even in kids. This is a review of many techniques, 20 studies included, 17 described LIT techniques, 4 ALL reconstruction, and 1 both techniques. We can divide techniques in all soft tissue techniques, like the one with hamstrings and fascia sparing we described, the ITB fascia sparing described by Coker, and the Coker-Arnold LIT, and bone tunnels technique, the modified Lemaire, the over-the-top Marcacci-Zaffagnini, and the ALL reconstruction. Results of the Coker fascia sparing has been reported by the authors with a failure rate ranging from 4 to 7%. And results of the Marcacci technique have been recently reported by 2 papers, no re-injury, no instability in all patients. And results of ALL reconstruction have been reported, of course, by Bertrand and his group in this paper, showing a failure rate of 2.6% and 95% of patients with no residual pivot shift at the follow-up. Green reported results of quad tendon, autograft, and modified Lemaire, 0 graft rupture rate, and 100% of returns to sports. And we also, in this recent systematic review we made with the Santi group, we showed that with different techniques, from 5 studies and almost 400 patients, their failure rate ranged from 0 to 13%. But most important are results coming from comparative study, comparing isolated ACL and exarticular reconstruction. First one, stability paper from Alan Gedgood, more than 600 patients. Total failure rate was 11 for the isolated and 4 for the combined reconstruction. But if we look at patients between 14 and 19, so the real pediatric patient, the difference was 15 versus 6%. We reported similar results comparing isolated ACL and Coker-Arnold technique. 50% of failure in the isolated group, 1% in the combined group, with a better stability, both for AP and rotational stability. And again, similar results from Perelli, 15% of failure in the isolated group and 6% in the associated group. This is a recent survey from members of the PRISM Society. They say that 55% of them perform exarticular reconstruction for primary ACL reconstruction, and almost 80% of surgeons perform exarticular in revision ACL. Indication are for severity of the pivot shift, knee hyperextension, ligamentous laxity, and type of sports participation. This is a preview for all of you of the incoming anterolateral consensus meeting to be in November with biggest expert in this field, and the statement on pediatric ACL and exarticular reconstruction reached 87.5% of agreement already at the first round. This is my algorithm of treatment for pediatric patient, usually pre-adolescent with a high risk for physis. I perform a physical sparing technique with hamstrings. For the early and middle adolescent with medium risk, I use all-inside technique with Cocker-Arnold, LIT, and late adolescent, I treat like adult, adding to an ACL, hamstring, ACL, LIT, or ALL reconstruction. So in conclusion, pediatric patients are the higher risk population for ACL injury, but also for ACL reconstruction failure. Soft tissue grafts are usually indicated for pediatric patients for ACL reconstruction. And short and medium-term follow-up studies showed lower failure rate and no specific complication when adding different LIPs to ACL reconstruction in pediatric patients. And soft tissue exarticular procedure should be used in patients with open physis and higher growth remaining. Thank you very much again.